Good morning, and we welcome you all to this week's clinical meeting. We will start with the first case presentation from Medicine 5 by Dr. Dorene Juana.
Good morning, everybody. I'll be presenting on behalf of Medicine 5. My clinical meeting is on Mrs. K, a 54-year-old female who had presented with ingestion of 10 tablets of amlodipine 5 mg. She had consumed it alone. She had not taken any other product along with it. She was taken to a local government hospital within 1 hour where the initial gastric lavage was done. And then she was referred here to CMC. When on presentation here, she was noted to have a pulse rate of 84. Her blood pressures were 120 by 70 and her respiratory rate was 18. And bilaterally, she had normal vesicular breath sounds were present. And her other systemic examination was normal. Her baseline investigations, her hemoglobin was 12.2. She had an elevated counts of 13,400, platelets of 2.7 lakhs, and there was no renal or hepatic dysfunction. And her electrolyte profile was normal. Chest X-ray done had shown no patch or infiltrates. On her ECG had shown sinus tachycardia, and her QTC was 547. So my topic is on amlodipine overdose. Amlodipine, when we look at, there is calcium channel blockers, is primarily dihydropyridines and non-dihydropyridines. Though non-dihydropyridines are the most studied ones, dihydropyridines have also shown to have, there is significant reports showing toxicity with dihydropyridines also. So both of them act on calcium channels, but dihydropyridines act primarily on the calcium channels in the vasculature. Hence, their primary function is of, they result in arterial vasodilatation and reflex tachycardia. Whereas in non-dihydropyridines like verapamil and diltiazem, they selectively block the calcium channels in the myocardium. Hence, they have peripheral vasodilatation and they have decreased cardiac inotropy and they have more of bradycardia symptoms. So this tachycardia, bradycardia is one of the prime differences between these two calcium channel blockers. Coming to amlodipine, amlodipine is a highly protein-bound molecule. Hence, it has a prolonged half-life, which also causes for a prolonged period of probable toxicity. The toxic dose of amlodipine is 5 to 10 times the maximum tolerated dose, which is 10 mg. The common features of amlodipine overdose is they can present with hypotension and tachycardia. Bradycardia, if there is in severe case of amlodipine toxicity also, we can have bradycardia. And features of fluid overload, they can have JVP elevation and non-cardiogenic pulmonary edema. Secondary to vasodilatation in the pulmonary capillaries, they can have pulmonary edema. And GRBS, hyperglycemia, because amlodipine also blocks the calcium-mediated insulin release in the pancreas, secondary to which you can have hyperglycemia. And in ECG, they can commonly be noted to have a prolonged PR interval or QTC prolongation. The initial therapy when it comes to amlodipine overdose, the mainstay of therapy is hydration. And frequently we need to reassess the mental status because though they initially have hypertension and shock, their mental status are fairly preserved throughout most of the initial period until one point when the cerebral perfusion drops and then they rapidly deteriorate. And hence we need to also look for features if there is any need for early intubation. Activated charcoal should be administered to all patients with CCB overdose, even if they are asymptomatic. And it is always preferable if it's within 1 hour of ingestion, but even up to 6 hours of ingestion, delayed activated charcoal is also acceptable. And if the patient is asymptomatic and has consumed a lesser toxic dose, then there is a requirement for only observation for up to 24 to 48 hours. No specific intervention is per se required. If the patient is mildly symptomatic, such as if the patient has hypotension and tachycardia, then the prime stay of treatment will be in the lines of isotonic crystalloids, an IV glucagon, high dose of IV insulin plus dextrose to combat the hyperglycemia, and IV lipid emulsion therapy because again it is bound it will cause in fastened volume redistribution of amlodipine. In case of severe symptoms, the patient will need stabilization of the airway. And it is always good to avoid agents which cause hypertension because amlodipine overdose also causes hypertension. And additional, we should keep rehydrating the patient with IV crystalloids. And for severe symptoms also, we again give IV lipid emulsion therapy and IV high dose of insulin with glucose. And vasopressors, the first preferred vasopressor is norepinephrine in amlodipine toxicity. Coming to the specific therapies, the IV glucagon, the though this is not very much preferred in given in much in amlodipine, it's more for the for in verapamil or diltiazem toxicity because it has it has increases the cyclic AMP levels and has a inotropic effect. IV lipid emulsion therapy, it raises the serum lipid levels markedly, and also as a result of which it increases the amlodipine's volume of distribution and hence decreases the plasma levels. The hyperinsulinemia euglycemic therapy is the high dose insulin with dextrose therapy, which so it has two mechanisms. One, it has insulin by itself has a positive inotropic effect, and insulin also helps to combat the hyperglycemia that is secondary to the CCB blockade in the pancreas. So initially we started off giving it as a bolus of 1 unit per kg is given of a normal regular short-acting insulin is given, and then followed by we can keep the patient on continuous infusion with 0.5 units per kg per hour IV insulin, and we also give dextrose to keep the patient euglycemic. Just to look at the two case reports which shows the extent of severity of a amlodipine overdose. So this patient was a case report who presented 51-year-old male who came to ED 7 hours after ingestion of 300 mg of amlodipine. Initially, the vital signs were all very unremarkable. Even the laboratory analysis was also very normal. And this ECG had only sinus tachycardia and QTC was 453. The patient had initially received calcium gluconate and was only on hydration therapy. But the patient progressively was noted to have dyspnea and also became very visibly tachypneic. And chest X-ray, which was done at that point, had shown interstitial pulmonary edema. And ABG had shown profound hypoxia was present, hence requiring high supplement oxygen. The patient was treated with IV diuresis and non-invasive ventilation and had gradually recovered. The final diagnosis that was made in the patient was an amlodipine-induced non-cardiogenic pulmonary edema. This was a second case report, which also had a similar presentation of a non-cardiogenic pulmonary edema, but also had a secondary complication of a diffuse alveolar hemorrhage, all secondary to amlodipine. She was a 39-year-old female who had taken 300 milligrams of amlodipine. The initial management with her was also IV crystalloids and calcium gluconate was given. Within 12 hours itself, she had developed chest pain, tachypnea, and hypertension to 97/63. So she was again treated initially with only fluid, and later subsequently she had become hypoxic and requiring intubation. And she was also started on vasopressors for her worsening hypertension. Within the next 12 hours, her hypertension had improved and her hypoxia had also improved. So she was gradually ventilatory supports and the vasopressor supports were weaned off. But subsequently, she had her respiratory status had again declined. She had severe hypoxia, requiring a re-intubation 72 hours after her extubation. Bronchoscopy, which was done at that point, had shown that she had multiple shown features suggestive of diffuse alveolar hemorrhage, for which she was treated with dexamethasone 20 mg IV, and she had subsequently recovered. She was extubated, and she was after 2 weeks they had done her repeat imaging. She was shown to be normal. Coming to our patient, she was initially, because all her vitals were stable, she was admitted in the ward primarily for monitoring. But in the ward, she had hypotension with blood pressures was 70/40. There was no tachycardia. She was initially treated only with IV crystalloids, with which after 2 to 3 hours her blood pressures had gradually normalized. So her initial QTC was 547. So we had repeated subsequent ECG BD monitoring, with which her QTC had actually normalized. The amlodipine half-life is around 30 to 50 hours. Hence, she was admitted in the hospital for monitoring for the same duration, and she was discharged after that.
Thank you. Thank you, Juana. Are there any questions from the floor? I would request the online participants to post their questions on the chat box if there are any. So meanwhile, the toxic dose is how much?
5 to 10 times the maximum dose, which is usually what we take is 10 mg. So 100.
100. Just about this hyperinsulinic euglycemic
Glycemia.
therapy. So when would you use it, and which group of patients would you think about initiating it?
If the patient is completely asymptomatic and they have not, the toxic dose is not enough, then patient can be just monitored, regular GRBS monitoring. But if the patient has had a significant dose ingestion, then it would always be advisable to continue the GRBS monitoring and initiate them on this hyperglycemic, hyperinsulinemia euglycemic therapy. Most of the case reports that I had gone through, even with moderate in toxicity, they had initiated the patient on the insulin dextrose therapy.
So how does it help?
It primarily helps only to counter. So because of the calcium channel blockade effect on the pancreas, there is a decrease in insulin, which subsequently causes the hyperglycemia in this amlodipine overdose. So by supplementing the insulin, and also we give dextrose simultaneously to maintain the patient in a euglycemic state, mainly to combat the effect of amlodipine. But insulin by itself has an inotropic effect, but that is more better. That is more useful in the other group of CCB blockade, because amlodipine per se doesn't affect the myocardium. So but in the other CCB groups, verapamil and diltiazem, insulin also has this other effect also by giving a positive inotropic effect.
So the HIET is mainly to counteract the cardiac effects. Not mainly with the glucose. So by giving them high dose insulin and dextrose infusion to prevent hypoglycemia, you try to help the myocardium contractility and glucose uptake into the myocardium. That is the basis of HIET. So usually HIET is recommended when the bradycardia and the hypotension are refractory to your conventional therapy in a patient with CCB overdose, not in any other setting, usually. Any other questions from the floor? I'll just check there are no questions on the chat. Okay. Thank you, Joanna. Thank you so much. We would